So welcome at this third lecture on solving the toll of depression on populations. This lecture will be on treatments of depression, because our treatments for depression, they work, but not good enough. And that's one of the main subjects I've been working on over the past couple of decades. And this is the third lecture as part of a series of lectures on solving the toll of depression on populations. And part of this series of lectures, I give those because I have to retire from my position as professor at this university. So I will briefly again give an introduction of the disease burden of depression. I do that because not everybody wants to listen to all lectures, and this may be boring for the ones who already heard it in the previous lectures, but I still think it's important to give the context of what we're talking about. So please bear with me. Then I will talk about the idea of meta-analytic research domain, stepping up from normal meta-analysis to much broader domains. Then I will talk about psychological treatments, psychotherapies for depression. What have we learned from these, of the effects of these interventions? And I will focus on the difference between the effects of psychotherapy, pharmacotherapy, and combined treatment, because that's the most used type of treatment. And then I will give, finally, some ideas how we can get to better treatments, because they work, but not good enough. So briefly, the introduction of depression as a public health problem. It's the most prevalent mental disorder we have. 280 million people with depression. If you look at the numbers, that's 63% of the total EU population. 80% of those people live in low and middle income countries. And the total cost of depression is $1 trillion. I also refer to the Lancet, the paper we wrote for the Lancet, which was a collaboration between the Lancet and the World Psychiatric Association. If you want to know more on depression, you really should read this paper. I was mostly involved in the writing of the treatment section, but there's anything on prevalence, on incidence, on risk groups, on prevention, so I can really recommend this one. I showed this also in my previous lecture, but I do think it's very important. It shows that depression is a disorder of the working age, meaning that that's the reason why it's so expensive. $1 trillion lost, mostly because of production losses. If we could use that money to develop treatment services, that would be a very good economic investment, so to say. In the UK, they used this reasoning to develop the IAPT program, the Increasing Access to Psychological Treatments. And they invest lots of money every year just to increase the number of people getting treatments as an economic investment in the UK. Treatments are effective, but the uptake is low, even in optimal conditions. And so 100% uptake, 100% of evidence-based treatments, then we still only have 33% of this reduction of the disease burden. So we need basic research, because we don't really know what depression is and where it comes from. If we have better knowledge, then we may find better treatments and better preventive interventions, but that's a long shot. That's a long-term investment. And you cannot expect that within the next 10 years or 20 years or 30 years, that will really lead to new treatments or preventive interventions. So if we want to do something about the disease burden of depression, we have to focus either on prevention. That's what my first lecture was about. We should focus on dissemination, simplifying treatment so that more people can benefit from it. For example, through digital interventions. That was the previous lecture. And in this lecture, I will focus on more effective treatments. How can we improve the effects of treatments? In order to do that, we first have to know if they are effective. Do they work? And what we have done in the past 15 years in my group is that we have developed what we call a meta-analytic research domain. And that means that we do not do one meta-analysis on one subject. For example, what's the effect of psychotherapy for adults compared to control conditions? Or what is the effect of CBT compared to other therapies? What we do in meta-analytic research domains is that we collect all the research in a whole field regularly. So in this, for depression, we do that every 4 months now. And we collect all randomized trials with psychological treatments, whether they're compared to other therapies, to antidepressants, to combined treatments in youth and older adults and perinatal depression, whatever. As long as it's a psychological intervention for depression, we collect it. And that has all kinds of advantages. So it's a lot of work. A ton of work, you can say, but the main advantage is that you really have a broad overview of this whole field. Everything that can be known from randomized trials on psychotherapies for depression, we know that, because we have all the randomized trials and we integrate them all into specific questions. And so anything you want to know about the effects of psychotherapy for depression, we know that because we have all the trials. We have the results of all these trials. Because we have all these trials, we can also look, for example, at secondary outcomes. That's not possible when you do a normal meta-analysis, because many papers don't report whether they have looked into the quality of life, for example. But we just go through all the papers and see if they've reported quality of life. And another advantage is that we do that in a very consistent way. So we have all these trials and we do meta-analysis, but they are all the data are extracted in the same way. We do the analysis in the same way. We use the same quality criteria. So we have a very cohesive picture of what these therapies can say. So another advantage is that we can see what the emerging topics are. So we can see whether there are new developments, because we every 4 months we look at the new trials that are coming up. And for example, 10 years ago, there was more and more research on depression or anxiety. So transdiagnostic interventions, which are not specifically at depression, but since 2005, for example, the number of trials in low and middle income countries has risen explosively. And we can see that because then we can also always look at these new developments and do a meta-analysis when there is enough research. Okay, but of course there are also always dangers and disadvantages. The main disadvantage is that it's a ton of work to keep it going. it's very easy to drown in all the work that needs to be done to get this updated. It's very difficult to get funding for it because many funders consider this as secondary data analysis, which is not very interesting. Another risk is that because we have these very big data sets, nobody else does that in the world, because it's a ton of work to develop it, and they know that we have the data, so they don't do that. Now we have made the data open, so then it's easier for people to add things, do things differently, etc., etc. Well, it's not just depression that we do this for. Depression is the biggest one, but we are also working on all kinds of other psychological treatments for all kinds of other mental health problems. Here's an overview. The green ones are ready, and the orange ones are people are working on it. So it's work in progress. But as you can imagine, this is a big project. Here we have made all the data open, which are ready to be made open. I won't go into it, I won't show it to you, but if you click on Start Analyzing, you see the different data sets which are there, and you can make selections out of the data and run meta-analysis online. So if you want to know whether group therapy works in perinatal depression, you just go there, select the trials, and run a meta-analysis online. If you want to know whether problem-solving therapy works in older adults, you go there, select the studies, and run it. So it's a pretty cool project. So what have we learned over these past 15 years on psychotherapies for depression? Well, we now have more than 900 randomized trials. And they have compared psychotherapies with control groups. They have compared one therapy with another therapy, compared with antidepressants, with combined treatments. There are separate studies on inpatients. There are all kinds of comparisons between treatment formats. Digital versus face-to-face, individual versus group, etc. Here you see the development over time, and what's the most important development is that the number of trials is still increasing rapidly. And this whole field is booming. Here you see the subsets, so we have separate subsets comparing psychotherapy with control, psychotherapy versus psychotherapy, pharmacotherapy, and a rest group. And the number of trials comparing psychotherapy with control groups, that's by far the biggest and is still increasing. So this is one where we did, we did some historical analysis, not published yet, to see where you can see how this development goes over time. We did that with Poisson regression analysis, so no meta-analysis. And as you can see, most studies until the mid-1990s were done in the US. And since then, more and more research is done in Europe. And now there's more research in Europe than in the US. But you also see that the number of trials in East Asia is coming up, and the number of trials in other countries. So outside Europe, North America, Australia, and East Asia is increasing rapidly. So before 1995, 75% of the trials were done in the US, and now that has gone down to 25%. So it's really changing. So this is one trial in which I think this is an error. But this is one network meta-analysis in which we compared psychotherapy pharmacotherapy and combined treatments with each other. And so what we... wait, sorry about this. So this is a meta-analysis we published this year on cognitive behavior therapy, which is by far the best examined type of therapy. Well, it includes more than 400 randomized trials with more than 50,000 patients. And so CBT is by far the best examined type of therapy. It's effective, it works. The effects are not very good, but they're good enough. It's not more effective than other therapies. That's what some people think, but that's not true. There's no evidence for that. It has been suggested that the effects are declining over time, which is not true. There has been a study, meta-analysis, in 2014 that suggested that the effects are declining, but that meta-analysis was flawed, and here we showed that it's not declining. The effects are smaller in children and adolescents and when there is no guidance, but that's also not different for CBT than for other therapies. So then I come to this other network meta-analysis in which we compared all these different types of therapy with each other. And this is the network. So CBT is the big one, but you also see behavioral activation, problem-solving therapy, third wave therapies, psychodynamic therapy, interpersonal psychotherapy, supportive counseling. And basically what we found is that all therapies have comparable effects, except for non-directive counseling. But that could be an artifact because that's used a lot as a control condition. And you don't know whether counseling is delivered as it should be in trials where it's explicitly used as a control condition. But usually these effects are reported in terms of effect sizes, which indicates the difference between the treatment and the control group in terms of standard deviation. So if you find an effect size of 0.5, the treatment and the control group differ 0.5 standard deviation after treatment from each other. You have never explained that to a patient, right? Because that's impossible to explain. It's even for many clinicians, it's very difficult to understand what that means, what is an effect size of 0.5. A patient will ask, yeah, but what's the chance that I will get better? And so what we did is we looked at the exact response, remission, change, and deterioration rates in one meta-analysis of a couple of years ago. We included 228 trials. We looked at response and remission, and this is what we found for response within the treatment group. So we looked at how many people get better within the treatment group and within the control groups. And we found that for most treatments, on average, the improvement was 41%. So meaning that 41% of people get better when they get a treatment. Meaning that 60% do not respond. And response means that the symptom level has decreased with 50% compared to baseline. So the half of the symptoms are gone. And if you look at the control groups, that's in care as usual control groups, the response rate was 17%. So the actual benefit of getting treatment is 41% minus 17%. Not so very good. And it means that the majority of people don't get better even when they get an evidence-based treatment. Better than doing nothing, better than not getting treatment, because then the chance of getting better is really very small. And you can try another therapy when this one doesn't work. But overall, the therapies are not that good. And so 41% response, a reduction of 50% of symptoms. But if you look at remission, that's even worse. Remission means that people are well, so they're not depressed anymore. They meet all the criteria that healthy people also meet. They're healthy again. And that's only 26% of people getting treatments are remitted. And that's 12% in care as usual and 9% in waitlist. So 75% of people who get treatment are not well after the treatment. I will come back to that when I talk about recommendations. Well, the next question is, how can we apply this? How can we apply that? We limited this to CBT, and we looked at all the treatment formats, so guided self-help, individual, group. I also talked about this in my previous lecture, but briefly, it doesn't matter how you apply CBT. That can be done individually, in groups, by telephone, by digital interventions, as long as there's human support. If there's no human support, then the effects are smaller. Then we get the question, does this work in all age groups? And so we did one big meta-analysis together with a group of John Weiss, who has focused a lot on research in psychotherapy in children and adolescents. And we looked how do these therapies work in the different age groups. What we found is that when people are adult, the effects don't differ. So younger adults, middle-aged adults, older adults. We now also have enough studies to look at older old people, so 75 years and older. And it really doesn't matter. The effects are very comparable. But in children and also in adolescents, the effects are significantly smaller. We looked in one study, which I don't report here, also at the response and remission rates in children and adolescents, and we found that the response rates in the treatment groups were the same in adolescents. We didn't have enough studies in children. But the response rate in the control conditions in adolescents was much higher than we find for adults. So, which makes sense. So adolescents do respond, but if they don't get treatment, the natural recovery, so to say, is higher than what you find in adults. We have also looked at all kinds of other outcomes like quality of life, social functioning, anxiety, self-esteem, hopelessness, dysfunctional thinking. And what you find is that if a treatment for depression is successful, that also improves all the other things, social support, quality of life, etc., although the effects are smaller. There is a number of studies looking at suicidality. So if people are suicidal and you treat them for depression, and we find no significant result on suicidality. But the number of trials here is also very small. But there is somebody working on an update of this, and they still find no significant outcome, which really is an important finding. There is also a small group of studies in mothers with small children, and then you see that if you treat depression in mothers, that also has a beneficial effect on their children, on the mental health of their children, of the interaction between mother and child, and parental functioning in general. So we have 900 randomized trials examining the effects of psychological treatments of depression, but only a handful of comorbid people with depression and comorbid other conditions. While we know that the majority of people with a depressive disorder also suffer from other comorbid conditions. And so for anxiety and insomnia, the results were pretty good. So if you have depression and anxiety, and you get a treatment that works both on depression and anxiety, same for insomnia. So your insomnia gets better and your depression gets better. For people with substance use problems, the effects are pretty small, much smaller than we find for other treatments, and also a small effect on substance use problems. Substance use is really a complicated factor in treatment of depression. But this also illustrates a major problem of the whole field, that we have 900 trials, but a very clinically relevant aspect, namely comorbidity, we don't have answers to that. So people working in clinical practice know how important, for example, personality problems are if you treat people with depression and a comorbid personality problem. We don't know how treatments do it for this population. So there's a lot to be done here. So we have examined all kinds of other things. No differences in students. That works also in students. When people have comorbid general medical disorders, it's worked in older adults and perinatal depression. Maybe we have smaller effects in primary care. I don't have the time to go into that. Chronic depression, maybe the effects are smaller. I already talked about comorbid substance use problems, smaller effects in subthreshold depression, which makes sense because there is not so much room for improvements. But we do, as I said in my first lecture, if you do treat people with subthreshold depression, you can prevent the onset of major depression later on. We did not find an association between the number of sessions. So we're repeating that now to see if that's, with all the new trials, if that still is true. But we did find an association between the frequency of sessions and the outcome, and that's important. I will come back to that later too. So if you give 2 treatment sessions per week, the effects are larger than when you give them once a week. So, and then I come to the work led by my colleague Irene Kariotaki. I already talked about this in my previous slide. This is an individual, in my previous lecture, and this is the individual patient data network meta-analysis of digital interventions for depression with guided interventions, unguided, and control groups, and then you can compare all 3 of them. And you can, when you go to this website, you can fill in the characteristics of one individual and see what the treatment does for this individual, whether this individual with these characteristics needs guided interventions or an unguided intervention. Very important for the development of personalized treatments. Well, this was the good news about psychological treatments. It seems as if they work and are very effective, which is true. But we have also a whole series of papers on all the problems of the field, showing that if you just look at all the studies done in this field, you heavily overestimate the true effects. And we know, for example, that waitlist control groups overestimate the true effects. Risk of bias indicates the weak spots of randomized trials. So were the trials done methodologically in the right way? We know the problem of publication bias. When studies are show no significant effects of an intervention, they're often not published. We know that for sure. So Ellen Driessen, who worked in our group, she looked at the NIH database to look for published for funded projects on psychotherapy for depression and looked which were published and which were not published. And so a quarter was not published. And when we went after the people doing these trials and they gave the data, so we could also see what happens when you adjust for the publication bias. And then, yeah, the effects drop with about 25%. If you adjust for that. And that's also what we find when we adjust for publication bias in a statistical way, because you can do that in statistical ways. And selective outcome reporting, where people change outcome measures, do other analysis afterwards, because these are give better outcomes than when you look at the original outcome measure. So if you adjust for all these problems, then the effect sizes go down with about 50%. So how do psychotherapy and pharmacotherapy compare with each other? We did a network meta-analysis in which we compared psychotherapy, pharmacotherapy, and their combination in depression. And yeah, 100 trials, 12,000 people. Response was the main outcome. And what we basically found is that at the short term, psychotherapy and pharmacotherapy have comparable effects. Combined treatment is better. And at the longer term, combined treatment is still better. Psychotherapy is probably a little better than pharmacotherapy. This is also true for chronic and treatment-resistant depression, for severe depression. So combined treatment is definitely better. This one was led by Toshi Furukawa. It's not only based on our database, but it includes also several other randomized trials. So here we looked at the acute phase treatment. That could be psychotherapy, pharmacotherapy, combined treatments, followed by maintenance treatments, which could be also, people could switch from psychotherapy to pharmacotherapy, from combined to psychotherapy, from combined to pharmacotherapy. So all the combinations were possible. And so 81 trials, 30,000 patients. Main outcome was response at 12 months after baseline. This is the network plot, and this is the outcome. And to summarize this, it shows that at the long term, at 1 year, with sequential treatments, combined treatment definitely is the best treatment compared to pharmacotherapy alone. And psychotherapy alone is also better than pharmacotherapy alone. I think this has major consequences for treatment guidelines. And this is one important paper that was also included in thinking about updates of the WHO guidelines, which are going on now. And again, I want to show you this idea of more personalized treatments. This is an individual patient data network meta-analysis of CBESP. CBESP, a cognitive behavioral analysis system of psychotherapy. It's the only therapy specifically developed for chronic depression. And so we collected all the data. We had only 3 trials. But the trials are very big, and so we had more than 1,000 participants, and so you could have CBESP, antidepressants, or the combination. And again, if you go to this website, here you can fill in the characteristics of the patients, and you can see what what is the best treatment for this patient. In this case, you see that it doesn't really matter very much whether you give antidepressants alone or pharmacotherapy alone or the combination of the two. And then you can talk with the patient which is the best of the three. But if you, for example, increase the level of anxiety, it's very clear that the combination treatment is better than either CBESP or antidepressants alone. So again, this is an important tool towards personalized treatments. So how do we improve treatments? Because we saw that they are effective. Psychological treatments, probably better than pharmacotherapy, especially at the longer term, but are not that good, right? 60% of people who get treatments, psychological treatments, don't respond. So what do you do with this? I always say to people working as clinicians that what happens is that when you work as a clinician, you think that you're treating somebody with an evidence-based treatment, and then you see that that person doesn't get better. So then you think, oh, maybe didn't I do the therapy right? Or maybe the diagnosis was not correct. Should I go back to the diagnosis phase and see what's really going on? Because this is an evidence-based treatment and it should work. But that's not the reality. You can do, with a depressed person, you can do a treatment, but it doesn't work. That's for most people. That's what you can expect. So how can you prove that? Prevention of depression is, of course, an option. I talked about that. Scaling up and simplifying treatments is, of course, also important. I already talked about that in my second lecture. I think we should develop no new treatments, formats or target groups. There's no reason to assume that digital interventions won't work for older adults with diabetes, while we see in our database all these new trials coming up saying this is the first trial in older adults with diabetes. Yeah, but why would it not work? I will come back to that. And we need research on sequential treatments, because what do you do with these 60% of people who do not respond? And there's hardly any research on it. Where do you start with? What do you give second? What do you give third? We don't know. We need to improve treatments for specific target groups. We need to personalize treatments. Stratification is important. And we should focus on the process of treatments, so the frequency question. I will work out a few of these things. So no new treatments, formats, and target groups. I think the innovation cycle we use in psychotherapies is wrong. So what happens now is that people working in clinical practice see all these people not getting better. And they want to learn they want to help people. They learn all these skills and then still all those people don't get better, or it takes ages before people get better. So they want to learn new things and are very eager to learn new and innovative things. And then you have people saying, okay, I've got this new treatment, which is much better than all the therapies you had, because based on my clinical experience, problems are caused by this in this way and are related to that. And if you focus on this issue, much better. And we can see that in our database. All these treatments coming up and being implemented, being researched, but they're never better than the ones we had. So then you get this new treatment, it's implemented, trials are done showing that it works, but then after a while you can do large trials, or you can see in meta-analysis, yeah, it's new and it's different, but it doesn't work better. So in the end, you have this whole innovation cycle with a lot of energy. People are trained, people, you know, you get a professional organization, but no patient gets better because of it. And so I think it's a waste of time. The innovation cycle is wrong. And what we really need is, for example, focus on sequential treatments. What do we do when do we start with CBT? Or do we start with behavioral activation? Or do we start with the third wave therapies? And how do you decide that? We don't know. And there is no way of deciding. We don't know who benefits from which therapy. And we don't know why we should start with CBT. And if people don't respond, the 60% who don't respond, who should we give behavioral activation? So there's clearly more research needed for that. And then I think we have all these problems, clinical problems that have not been solved. Like, for example, comorbidity. Most people with a depressive disorder also have a social anxiety disorder or a substance use disorder or a personality problem or whatever. We don't know what that, we hardly have any knowledge on what the implications of that are, and should we adapt the treatment or not? What do you do when those people don't respond to treatment? Do you give a treatment for the personality problem, although it's a secondary problem? We don't know. And while these are the basic clinical questions that need to be answered, not another randomized trial on another. We already have 900 of those, while the basic clinical questions have not been answered. Same is true for chronic depression. So the one big driver of the disease burden of depression is that a lot of people don't get better. They just remain chronic depressed for years, and we don't know what to do with it. There's one therapy specifically developed for chronic depression, CBESP, as I showed you. Another thing is relapse prevention. We know that people get better, but then lots of them relapse again. Stratification is another thing, and that's, I showed you the work of Irini Karyotaki, my colleague, who has done a lot, who is doing all these IPD meta-analysis. But there are other ways to stratify. There are also several large randomized trials now going on with several thousands of participants, because that's the number you need to really look at moderators. And one big disadvantage of IPD meta-analysis is that you have to work with the predictors and moderators which are examined in the trials. But that's pretty limited. So we need these very large, expensive, randomized trials with thousands of people where we can really look at all these potential moderators of outcome with sufficient statistical power. And then I think, yeah, we know all these therapies have comparable effects, but if you deliver them twice a week, they're better. Why don't we do that? We also know, for example, we have not done research on that, but there is research that if you give feedback, structural feedback to patients about how things are going, and you do that every couple of sessions, and then the patient and the therapist talk about how things are going, that increases the effect size. It has nothing to do with the content, but more with the process. And so these kind of innovations are, that's another way to improve outcomes. And if you're interested in these things, I will work these out in the next lecture, where I will focus on the future. Thank you for your attention.